Tim,
Paul,
today we are going to talk about the meninges and the cerebral vasculature.
that sounds fun. Why are
Yeah,
we doing
yeah,
that?
yeah. This formerly would have been with the brain in a combined lab, but we split it up into two fantastic labs.
So no brains today. Deal. I can live up to that
We're,
standard.
we're done with the brain, Tim.
Okay.
No more brains allowed.
Okay. I can live up to that.
All right.
I'm just an empty brain wrapper.
You know, you get your skull, you get your cranium. We don't care what's in there today. Well, we care what's just inside the cranium and the vessels supplying
Mm,
that region, but we're not talking about the brain today as much. Um,
right.
Let me click my presentation. I want to start out with a pithy quote from one Tim Bassel, clinical pharmacist. He said this: "The pharmacist is a mandatory responder to all stroke codes at our medical center and every hospital I have worked at." A side note, Tim really loves to use parentheses. Every opportunity he gets, he puts something in parentheses, and there's an example right there.
All my emails, all of it. Yeah.
The pharmacist is responsible for the fast and safe administration of alteplase, much of which happens in CT scan. I'm not sure what's going on with the brackets there. Uh, you're
That was
not as
you.
helpful
I
if
do parentheses, you do brackets.
I didn't put those brackets there, did I?
You definitely put those brackets there. You were just trying to clarify what I was saying.
Oh, you just wrote CT and I threw the brackets in as well.
Yes.
That's appropriate use of
Yes.
brackets for
You
editorial clarification.
you were patronizing our students, is what you were doing.
No, I was using appropriate punctuation to indicate that this was an editorial, inserted editorially, that you didn't actually
You,
use that word
you
because you,
appropriately editorialized that you were patronizing our
yes,
students.
no, I, I, I'm trying to teach here, Tim. I'm not trying to confuse.
Okay.
I'm trying to clarify.
Okay.
Uh,
Proceed.
Tim, t Dr. Bassel finishes by saying, "You're not as helpful if you don't know the anatomy." And then came this. Now give me your lunch money. I'm not sure.
Uh,
I'm not. I think was that meant for me? Did I
yes.
think I asked you to provide a quote, and then you're like, "Great, here's your quote. Now give me your lunch money." So I just want to reaching in my pocket here. What's lunch cost these days? $20? I got a 20 here with your name on it, Basil, for providing that
Perfect.
quote.
I've been stalking you for that money for a while.
Was this a long night in the hospital?
I had the night off last night from the hospital,
No, I
not
mean
from
when you gave me this
Joey.
quote. Okay,
Yeah.
so Tim's making the point that we are teaching basic anatomy for pharmacists. It is important for pharmacists to understand the meninges and the very basics of the vessels supplying and draining the brain. So here we go. Um, let's start with a hypothetical case involving an 18-year-old male patient who arrives at the emergency department following an accident on the ski slope. He's confused and complaining that his head hurts. He lost consciousness after colliding with a tree. Uh, Tim, you do some skiing, right?
I sure do.
Do you wear a helmet when you ski?
I do now.
You didn't, not when you were 18.
I wore nothing but a hat until I was probably 22 years old, maybe 21.
Okay, well, this
I
kid
think my parents
unfortunately
got
doesn't.
me a helmet the year I graduated college.
Okay, well, this 18-year-old hit a tree,
Yeah.
knocked him out, but he regained consciousness in the ambulance, um, or the snowcat or whatever they used to get into the emergency department. He's currently dazed but oriented to time and date and place, and he does remember the accident. On physical exam, he has normal blood pressure, normal heart rate. His respiratory rate is normal. He's got abrasions and swelling above his right ear where he struck the tree. On the neurological exam, his pupils are equal and round and responsive to light. He can move his eyeballs normally, which is a useful test of the cranial nerves that innervate those muscles that move the eye. Um, he has numbness on the right side of his face, indicating that there's a particular nerve, a cranial nerve that may be damaged on his right side. On imaging with a radiograph, it's clear that he has a skull fracture laterally on the right side And a CT scan reveals a biconcave, that is lens-shaped, dense mass between the brain and the skull. And I think we're going to see an image consistent with that. Now, recall
Like,
that in a transverse or axial image like this one, we imagine the patient lying on their back, supine, with their feet projecting out at us. So we're looking at the underside of a transverse section through the skull and brain. The patient's right is on our left, as indicated by the R and the L there. And so what we're interested in here, what catches our attention is this bright biconcave mass that is blood pooling and clotting in a particular region, and its localization there is affected by the meninges, as we will see shortly. Okay, and there are some other alarming abnormalities in this image as well that we can come back to in a bit. And just one more follow-up point. Hours later, the patient loses consciousness again. His right pupil dilates. That is an indication of a lesion of a cranial nerve as well. His heart rate and his respiratory rate both fall below normal. So his condition has progressed into a severe state.
it's called having a bad day.
Having a bad day, is that?
That is the medical term.
I agree. Okay, so we're going to find out in a little more detail what happened to him shortly here. That's a lead-in to discuss the meninges. And before I go any farther, Tim, meninges refers to a nested, as it says here, a series of nested membranes surrounding the brain and spinal cord. We have a central nervous system. It is composed of the brain plus the spinal cord, and they are wrapped in a triple layer of nested membranes called the meninges.
Brain wrappers.
And I would be remiss if I did not point out that the singular of meninges is
Meninx.
it's meninx. Yes. So you never hear that word, but that's something I like to bust out at a party. Yeah.
If I, instead of saying meninges or meninx, if I just write brain wrapper, do I get credit?
I mean, either one of us would get kicked out of that party. But I'm trying to leave, and I'm doing so in a cool fashion. When I start telling everybody that meninx is the singular of meninges, if you say brain wrapper, people just assume that
you're the one who should have been on the table in that case.
Okay. But they are brain wrapper. You know, these are wrappings for the brain, and in fact, well, I think I'm gonna make these points on this slide shortly. We're gonna go from outside to in, from superficial to deep. The outermost layer is called the dura mater. Dura for hard, like durable or tough. The arachnoid mater lies just deep to the dura. Arachnoid because there are fine filaments of connective tissue tethering this particular meninx to the surface of the CNS, and those fine filaments reminded somebody a long time ago of cobwebs, of a spider web, and so arachnoid for the spidery layer or the spidery membrane. And then finally, the pia mater. Pia because this particular innermost layer is very faithful. It follows faithfully the contours, the folds and crevices of the brain and the spinal cord. And so pia mater is our innermost layer. And the function of these wrappers, these meninges, is to contain, to contain the cerebrospinal fluid. Imagine the brain and the spinal cord suspended in a bubbly, oxygenated, warm spa, right? Floating in this warm, nutritious bath. And that's basically how the brain and spinal cord are rest inside our dorsal cavity that contains our CNS. So this cerebrospinal fluid suspends the central nervous system. The brain, which we will examine in lab, the brain in situ, in vivo, has no rigid internal structure at all. It is very gelatinous and cannot support its own weight. So suspending it in this fluid is critical to maintain the structural integrity of the brain. The brains that we examine in lab, they are stiffer with more structural integrity because they've been fixed, because they're embalmed with fixative. But the unfixed brain is extremely gelatinous. If you hold it in your hands, it will just kind of melt. So we need to suspend the brain and the spinal cord in a bath. It's floating in this fluid. That protects the CNS. It also absorbs shocks. So if you strike your head, against a door frame or a surgical lamp in the lab, um, the cerebrospinal fluid helps absorb the impact and prevents the brain from slamming right into the skull. If the brain does impact the cranial bones with any force, that can produce a contusion, a bruise, and a concussion. So we want to avoid that, and the CSF helps limit or preclude that possibility in all but very high impact collisions. And then finally, it does carry some nutrients and it filters some waste. The CSF, in fact, there's a growing understanding of how the CSF is sort of flushing out metabolic wastes, particularly overnight when you sleep. So those are the functions of the meninges. Now let's think about them. Let's think about their anatomic relations while Tim heads to get his.
Well, I'm doing my own demonstration right now, where the brain is like the tofu inside the skull of my air fryer,
Oh, good
and
Lord.
and it has to be scrambled or it burns.
Okay, so Tim's going to
Brain.
demonstrate with his tofu brain.
Yeah.
The meninges wrapped around them and how the brain is suspended in CSF. Is that what you're doing?
Not well, there's no CSF in here, just brains. And
When you buy the tofu, you get it in a little box, and there's like you peel the plastic wrapper. Isn't it sitting in fluid?
oh yeah, that's true. Um,
Well,
I don't know that I want to take the food analogies too far though for the anatomy class.
I mean, we're already here, Tim. It's
I suppose I opened the door
we
for
we're
that.
either we're either we're either going for it or we're gonna walk all this back and like restart the recording.
Mhm.
Okay, so back to my cartoon here. What I'm trying to show here is a frontal section, a coronal section through the top of the skull, like maybe the parietal bones, and the very top of the brain where we would find cerebral cortex and a little bit of deep white matter. And I'm going to illustrate these from outer to innermost, the three layers of the meninges and how they relate to the cranial bones and the brain. So here's the dura mater in green. The dura mater largely runs against the deep surface of the cranium, but in certain spots reflects off the bones. As you see here, there is a midline, vertically oriented fold of dura. We're going to name that. Maybe we won't actually. I think we dropped that one. But anyway, we'll observe it in the lab. There is a prominent fold of dura that actually separates the two cerebral hemispheres. So the right half of the brain, the left half of the brain have this fold of dura projecting in between them and sort of longitudinally oriented like that. Okay, in the sagittal plane. And so where we have this reflection of dura off the deep surface of the bone, it creates a fold, a dural fold. And interestingly, we will find that inside these folds, there are spaces for veins to run. And we call these veins sinuses. They are dural venous sinuses. Dural because they are protected inside the dura. They travel inside the dura. Venous because they carry venous blood, deoxygenated, exiting the brain and heading back toward the right atrium of the heart. And sinus because they tend to be fairly large veins, and the blood can kind of pool and slosh around in them for a while. And so that is we use that term. We use the term
So
sinus.
sinusitis is not talking about these things.
No, no, no.
When I spray some nose spray in my nose, it's not going into my dural venous sinuses. It's going into my paranasal sinuses. So these are completely different sinuses filled with
Mhm,
completely different stuff in a
mhm,
completely different place.
mhm. So collectively, if you think of all the places in the body where we call something a sinus, it literally means recess or bay. It implies a place where fluid can pool. We talked about the paranasal sinuses. Those are air-filled sinuses inside bones that line that are off to the side of the nasal cavity. This is a blood-filled sinus. There are other blood-filled sinuses, including one that runs across the back of the heart, including the carotid sinus, which is an arterial sinus. These are dural venous sinuses. They're essentially large veins that run within the folds created by the dura. And we're going to come back and name some of those and find them in lab, these dural venous sinuses. So that's the dura mater. Just deep to that is the arachnoid mater. Okay, that's our spidery membrane. This is the one that's connected. It's tethered to the surface of the CNS by thin connective tissue filaments. Let's see if I actually drew those. Yeah, there we are. So imagine a cobweb-like array of thin filaments that anchor the arachnoid mater to the surface of the brain or spinal cord, and that gives it kind of that spiderwebby appearance. This is something I need to point out here. In lab, the arachnoid mater is going to have a distinctly different appearance than is pictured here in this cartoon, where I'm trying to portray the arachnoid as it exists in vivo in life. The arachnoid is inflated, if you will, and lifted, elevated from the surface of the brain and pressed up against the underside of the dura by pressurized CSF. And we're not talking about a ton of pressure here, just a couple millimeters of mercury, but it's enough to kind of cause the arachnoid to billow up and outward to the limit allowed by these connective tissue filaments. Once our donor dies and the CSF drains from their dorsal cavity, the arachnoid now collapses against the surface of the brain. So in lab, we will see the brain and we will see a translucent film of arachnoid mater clinging directly to the surface. That's not how it is in life. In life, it would be elevated from the surface as we see here. Okay? So that's our arachnoid mater with CSF kind of pressurized underneath or deep to it. And then finally, in blue here is the pia mater. And note how the pia faithfully follows the contours of the brain, dipping and weaving with every crevice, every fold, every sulcus on the surface of the brain. The pia mater we cannot demonstrate to you with the unaided eye. It is microscopic in its dimension. It's microscopically thin. We know it's there from histology, but we can't peel it away from the surface of the brain and demonstrate it to the unaided eye. What we can do, Tim, is put a pin into the brain and then ask.
Name the membrane indicated.
Yeah, name the membrane pierced by the tip of the pin. Yeah, and that would be pia mater. Okay, that's how we do it. So that's the layout. That's the organization of these meninges. And now I want to talk about some clinical conditions that arise. Imagine a hemorrhage, and a hemorrhage occurring on one side or the other of these three nested membranes. A hemorrhage in the brain can lead to a hematoma, which is where blood has pooled in a particular spot and then clotted into a mass, a solid mass. If that hemorrhage occurs between the bone and the dura, Tim, we would call that an epidural on the dura, epidural hematoma. Okay. And that's going to have the fact that the dura is very tough and leathery. It sort of keeps the hematoma localized in a particular spot and gives it a particular shape. I want to go back briefly to when I first brought up the dura mater. I think you were running around doing some tofu stuff, and I got distracted. And I forgot to say that the favored popular interpretation of dura mater, the etymological sort of meaning behind it is to say it's the tough mother or hard mother. I think the probable truth is that there was a mistranslation when a lot of anatomic knowledge was lost from ancient Greece, but treasured and kept alive in the Middle East with Arabic, in the Arabic languages, and then transferred back to Rome. I think there was a mistranslation in there somewhere where mater actually was supposed to be membrane, and then it got changed to mother. So somebody messed up. So it's supposed to be the tough membrane.
How very woke of you, Paul.
What's that?
How very woke of you. How very diverse. How very DEI to include this story of history and cross-cultural exchange. You're probably going to get fired.
Well, no, I'm not. I can back this up. I've got sources. I've got sources, Tim. I've got some old
Trade it.
anatomic texts, and one author argues that there's nobody named it hard mother. It was hard membrane, and then somebody transcribing some text blew it, made a typo, and now I got hard mother. Okay, which everybody loves because it's funny.
Mhm,
But I'm just telling you, sometimes we just make stuff up for laughs. I'm not
mhm.
above that. All
You're
right, so
also
we
not above criticizing the ancients in their
who knew
translations of
barely
anatomical
who got
terms.
basically everything wrong. I mean, let's face it, they didn't know what was going on half the time.
Mhm.
Do you want to bust out that Jack Handy?
Oh yeah, that quote. Like we like to, it's easy to mock the ideas of the ancients, but can't mock them to their faces. And that's what bothers me.
This is what annoys me.
Yeah,
Okay. The students are like shaking their heads going, they don't know what we're talking about.
this is
Okay,
all
Jack
getting
Handy,
edited
look it
out.
up. Jack Handy's deep thoughts. Epidural hematoma between the cranial bones and the dura. Um, a subdural hematoma happens underneath, deep to the dura, and would collect between the dura and the arachnoids as much as the arachnoid. Well, it's part of the blood-brain barrier. It can contain the blood. But in that case, I think the blood would spread potentially more.
Hmm.
It might have a greater spread, whereas the dura up against the bone will sort of limit the spread of blood from
Mhm.
a bleeding vessel. And then finally, subarachnoid is deep to the arachnoid, and that can spread all around, in the CSF filled space. And so, and I should point out here, as I have to move these window panes to see what I wrote here. The blood comes into contact and
Brain.
um, can injure neural tissue. It's a neurotoxic. Also, I've got a note here about small arteries where you might need medications to control vasospasm.
Yeah.
Tim, this sounds like something that you might have said, and then I
Oh
just wrote it
yeah.
down. Do you want
So
to?
that so that red line on the screen in front of you right there, the arachnoid mater, that basically outlines the outer extent of what we call the blood-brain barrier. Everything inside of that line is not supposed to come in direct contact with the blood. Outside of that line, there are capillary beds that are like kind of leaky and like, lymph bathes around, but inside that line is a very tightly controlled environment. It is cerebrospinal fluid under that membrane, and it's not supposed to be anything else. And if you start leaking blood out of a ruptured blood vessel underneath the arachnoid membrane in a subarachnoid hemorrhage, subarachnoid hematoma, you damage brain tissue, putting you at increased risk of seizures. You damage the blood vessels supplying that brain tissue, putting you at risk of cerebral vasospasms that can actually kind of shut off blood flow. It's almost like having a little mini stroke. And we have medications to deal with both of those things. So the pharmacotherapy, the drug therapy of a subarachnoid hemorrhage is very different from the pharmacotherapy of an epidural or a subdural hemorrhage. There are increased risks involved.
Okay. All right. Well, thank you for that edification. Back to my presentation here. And as I had mentioned, blood in direct contact with neurons, that's not good for the neurons. And did you mention anti-seizure meds to
Sure
if
did.
there's a yeah, okay. So if the blood affects neural tissue and neural activity. Um, Finally, so we've covered epidural, subdural, subarachnoid, and then a bleed within the brain. Again, since blood is toxic, if it comes into direct contact, it will destroy neural tissue. So a bleed deep to the pia is literally a
We
hemorrhage
call it
within the brain.
intraparenchymal. Yeah.
Intraparenchymal, where parenchyma means the functional tissue of an organ,
Mhm.
and that's our neural tissue, and that will destroy, different, whatever part of the brain the bleed is occurring in, which obviously can have devastating consequences for the patient's nervous system.
Or seriously injure.
Yeah. I want to come back. This is the MRI, I think it was. I think that's what this image is. That shows the biconcave mass pooling on the right side of the cranium. And here, this biconcave shape is characteristic of a epidural hematoma. That is, the blood is right up against a cranial bone here, and then where it's pooling and collecting, it is pooling between the bone and the dura, which is containing the bleed in this particular spot. But the mass of blood has pushed the dura away from the bone. It has also impacted the brain itself. There is some pretty clear evidence here, looking at these fluid-filled spaces, these cerebral ventricles, that everything is being displaced from right to left. And this is a very dire situation for a patient where a growing mass of blood, in this case, is putting pressure on the brain and shoving it in a direction that can cause additional damage, not just from the compression, but because the brain itself, as it slides leftward, can scrape across some of those dural venous folds that we mentioned. And those dural venous folds are unforgiving, unyielding, and rather sharp at their edges. And so they can seriously damage neural tissue that's scraping across. I'm going to come back. I'm going to come back to it right here, right now. So herniation. This hernia, that term has come up before, certainly when we were talking about the inguinal canal, and maybe in a few other cases this course. Herniation is a condition in anatomy where tissue is displaced from its normal location into another space that it does not normally occupy. And depending on the amount of tissue displaced and exactly how it's pushed there, that can cause damage. If it's entrapped in that space, if it's twisted or constricted or strangulated there. So herniation refers to displacement of tissue into an abnormal space and may or may not be accompanied by damage to the tissue that's herniated or other surrounding tissues. What causes herniation? And here we're going to address the herniation of the brain, herniation of neural tissue. Inflammation, which comes along with which involves swelling, that can cause herniation, can cause brain tissue to herniate. A hemorrhage, as we just saw with that epidural hematoma, a large mass of blood can push the brain in one direction or another. A tumor growing, that's another mass that can displace brain tissue. So imagine a herniation that forces the right hemisphere of the brain downward away from, say, the parietal bone. That might cause that right hemisphere of the brain, the right cerebral hemisphere, to herniate and scrape under that stiff dural venous fold that's illustrated here in green. And that could damage that tissue severely. Okay. So that's the concept of herniation of the brain. And that's bad news if that happens. Yeah. So the diagnosis for our patient is an epidural hematoma with elevated intracranial pressure and potential herniation, or we saw evidence of herniation in the brain. That condition can progress over a period of time. In his case, I think we mentioned a couple hours, something like that. So this is a particularly dangerous situation because it can appear that, well, the patient, they got a lump on their head, they got knocked in the head, but they're okay now. They're awake. They remember what happened. They know who they are and where they are and what day it is. But inside the cranium, the bleed has not stopped. They're still hemorrhaging, and the blood is accumulating in this mass that's getting larger and larger. And so over a relatively short period of time, this can progress. You can progress from awake behaving and relatively normal, just with a headache. Patient could just be reporting a headache to lethargy, stupor, coma, and then death. And that can happen in a relatively short period of time. So with an injury to the head like that, a well-equipped and knowledgeable healthcare team won't release a patient without a scan. They're going to want to see, are you bleeding inside your cranium? Do we have a hematoma developing here? And if so, we're going to have to deal with that emergently.
Yeah. And when they do find a bleed like that with a shift, that would be a brain code. So just like we have code blues for patients who have cardiac arrest, stroke codes for patients having other kinds of strokes, we have STEMI codes for patients having heart attacks. A brain code is an actual or imminent herniation of the brain in an acute situation, and that is about as urgent a code as they come. So, and pharmacists are called to that.
Brain code. What you mentioned, this is a total aside here. You mentioned code blue is a cardiac condition. Well, what's code red?
Fire in the building.
What's that? A
A
fire.
fire in the building.
Okay, well, that should.
A code
I
a
would have
code
said
gray
gray.
or a code green is usually an unruly patient or somebody starting a fight in the building.
Code green for
Yeah, a
fighting.
code Adam means that a child has been abducted. There are all kinds of codes that get called overhead in a hospital.
I'm just wondering who assigns these colors because I would have put red for cardiac arrest and orange for the fire.
A
Uh,
lot of them are facility specific. When I worked at
oh,
Sharp, it was code yellow for an unruly patient.
oh my God, they're not standardized?
Um,
That's crazy.
Many are, some aren't.
That's crazy. Okay.
Unruly patients or like situations like that, non-standard. Um, Most hospitals that have pediatric or labor and delivery floors have code Adam, which is a reference to a kid named Adam who was, kidnapped out of the hospital.
Yeah.
Um, and code red is a pretty universal for fire. Code blue is pretty universal for cardiopulmonary arrest. So if patient's heart stops or they stop breathing, that's code blue.
The air, that's blue. Yeah. Okay.
Yeah, and brain code isn't really a color, but that's what we use in our hospital for exactly this, what you were talking
Gray.
about. And pharmacist is called to that, and we carry a box, and inside that box is medications that we use to decrease intracranial pressure, which you might be coming to shortly in the lecture. So I don't want to.
Actually, no, Tim. We addressed that in I'm not sure where you were, but when we did Lab 12, we
Oh,
covered.
I probably wasn't paying attention.
I think you were there for the recording. You were just sleeping through it, probably. Anyway, thank you for the addressing all those codes for us.
Uh-huh.
Really not anatomic, but frankly
Mhm.
fascinating, very interesting, and I'm sure all students will appreciate.
And totally irrelevant. And now that I've taken 5 minutes of your time, I'm not going to test you on any of it.
Okay.